Then hemoflagellates, blood flagellates, that is nothing but Leishmania and trypanosoma. Both Leishmania and trypanosoma, they exist in 4 morphological forms depending upon the arrangement of flagella. They are called as amastigot, promastigot, epimastigot and trypomastigoid form. There are 4 mastigoid forms, there are 4 morphological forms. Amastigoid form is round, having a exostyle in the inside, but there is no flagella outside. So, absence of flagella, that is why it is called as amastigoid form. Promastigoid form, flagella is present anteriorly, anterior flagella. Epimastigoid form, flagella arises laterally, lateral flagella, whereas trypomastigoid form, here they say that flagella arises posteriorly and traverses as an undulating membrane, traverses as an undulating membrane. Okay. In Leishmania, AP forms are seen, AP for A and promastigoid, whereas in trypanosoma all forms are seen. However, the infective form and diagnostic form is trypomastigoid form. The infective form and diagnostic form is trypomastigoid form. Leishmania, AP forms are seen. AP means amastigoid and promastigoid forms are seen. Amastigoid form is the human form. It is present inside human body as LD bodies. It is present inside human body as LD bodies, and this is the diagnostic form. This is the diagnostic form, whereas promastigoid forms are insect form, hence they are the infective form. They are the infective form. Fine. So let us discuss Leishmania. Leishmania, which is the infective form I told? It is transmitted by what? Leishmania is transmitted by sandfly. And sandfly, which form will be there? Promastigoid form. So when the sandfly bite, the promastigoid form will be discharged onto the skin, and they will be taken up by skin macrophages, and the macrophages, so promastigoid form will be taken up by skin macrophages. So this is the promastigoid form which is taken up by the skin macrophages, and inside the macrophage pro to A transformation will take place. Then macrophage carrying plenty of amastigoid form are carried away to various organs via the bloodstream, and this is called as LD body. LD body means it is nothing but it is a big macrophage containing plenty of amastigoid form, which is carried out to various organs. Various organs like spleen, bone marrow, lymph node, etc. Okay. Overall life cycle of Leishmania. So Leishmaniasis is of two types: old world Leishmaniasis and new world. Old world Leishmaniasis is due to three important members: Leishmania donovani, old world, new world. Why they are called like this? Old world means Asia and Africa, new world means America. So Leishmania donovani Leishmania Leishmania tropica and Leishmania Ethiopia. These are the member of Old World, whereas New World is Leishmania brasiliensis, mexicana and Chagasi. These are New World Leishmania species. Donovani causes VL. What is VL? Visceral leishmaniasis, also called as Kala-Jar. It also causes PKDL. Tropica causes cutaneous leishmaniasis, which is called as oriental sore or Delhi boil. It is endemic in Gujarat, I mean Rajasthan. It is endemic in Rajasthan. Ethiopia causes diffuse cutaneous leishmaniasis. Diffuse cutaneous leishmaniasis. Brasiliensis causes mucocutaneous leishmaniasis, which is called as Espundia. Mucocutaneous leishmaniasis. Mexicana causes a ear lesion called as Chicrello ulcer. Espundia usually affects the nasal septum, whereas Mexicana causes a ear lesion, a lesion in the ear described as Chicrello ulcer. Chagasi can cause cutaneous leishmaniasis as well as visceral leishmaniasis. Of course, it is the only species in New World which can cause visceral leishmaniasis. Then vector. Regarding vector, Old World leishmaniasis, the vector is phlebotomous. I mean both the vectors, I mean sandfly only, but sandfly of the genus phlebotomous for Old World. New World sandfly of the genus Lutzomia. Lutzomia. For Donovani it is phlebotomous argentypis. The species is argentypis. Tropica it is phlebotomous sargenti, and Ethiopia it is phlebotomous longipes. Argentypis, sargenti and longipes are the respective vector for Donovani, Tropica and Ethiopia. So this is again a very important table what they can ask in the exam, so you have to remember. Let us discuss a bit about visceral leishmaniasis or Kala-Jar. As I told you, the manifestation of visceral leishmaniasis is depending upon the organ affected. Where the LD bodies are deposited, I told. LD bodies are carried out through blood and they are deposited in various organs. Which organs? Spleen. So you will have a splenomegaly, huge splenomegaly. Bone marrow deposition lead to bone marrow suppression. That causes pancytopenia, and as a reflex you will have polyclonal B cell activation, so hypergamma-globulinemia. Pancytopenia, and to compensate that hypergamma-globulinemia, non-specific antibodies will be produced. Lymph node also will be affected mainly in African patients. And in Indian patient, what it is called as in India? Kala-Jar. Kala-Jar means Kala is black, that is you will have hyperpigmentation, and Jara is fever. So hyperpigmentation and fever are the two important features of Indian form of visceral leishmaniasis. And in VL, after the recovery of VL, maybe 2 to 20 years later there is another manifestation of leishmaniasis which is called as PKDL, stands for post Kala-Azar dermal leishmaniasis, post Kala-Azar dermal leishmaniasis, and they say that this post Kala-Azar dermal leishmaniasis is seen in 2 to 10 years after the effective treatment of VL, and is usually seen in India as well as in African country named as Sudan. India and Sudan, both the places it is there, and the lesions are usually non-ulcerative, hypopigmented, nodular lesion. So, this is a description of PKDL lesions. We should not be confused with that of hyperpigmentation of Kala-Azar. Kala-Azar will have hyperpigmentation. Here hypopigmented, non-ulcerative, nodular lesion. Nodular lesion. Okay. And what happens in HIV individual? VL in HIV people. In HIV individual, they say that the routine hepatosplenomegaly will be absent. Instead of that, you will have more respiratory and more GI symptom, like you will have dysphagia, dyspnea, etc. The routine hepatosplenomegaly will be absent. Instead of that, more respiratory and GI manifestations may be seen. Fine. So, lab diagnosis of Kala-Azar. Kala-Azar, the lab diagnosis, first is specimen collection. Which is the specimen of choice? The most sensitive specimen is splenic aspirate. Splenic aspirate, but usually we splenic aspirate we do not do because of the risk of splenic hemorrhage. So, the most common specimen will be bone marrow aspirate. Specimen in African patient, lymph node aspirate. Specimen in HIV infected people, they say that the buffy coat area you have to, that is peripheral blood only is the specimen of choice, but peripheral blood you have to centrifuge and the buffy coat area is examined in HIV infected people. Peripheral blood is taken, centrifuged, and the buffy coat area is examined for HIV infected patient, and when you examine, what you will get, all this, when all this specimen, when you do a microscopy, what form will be seen? LD bodies. LD bodies are what? Amastigote or promastigote? Macrophage containing amastigote. But all these specimen, when you subject to culture, the culture medium is triple N medium, and Sneader's Drosophila medium. Sneader's Drosophila medium. So, in this medium, in the culture medium, they say that amastigote to promastigote transformation takes place. So, the promastigote forms are seen in culture, whereas amastigote form in the form of LD bodies are seen in where? Smear microscopy amastigote form and culture promastigote form. Apart from that, antibody detection, antibodies may be non-specific hyper gamma globulinemia, what is there, that can be detected by various antibody detection methods like Napier's aldehyde test and Chopra's antimony test. These tests detect the non-specific hypergammaglobulinemia. So these are outdated tests, we don't do. What we do is specific anti-Leishmanial antibody detection. This is done by ELISA, immunofluorescence assay, direct agglutination test, okay, complement fixation test, complement fixation test also they say it is not very specific, so you can remove. What you can do is you can, the last but the most important is immunochromatographic test, detecting antibody against RK39 antigen. Immunochromatographic test detecting antibody against RK39 antigen. So this is upcoming, this is quite popular nowadays. Apart from that, skin test can be done, that is Montenegro test, Montenegro or Leishmanian test, Leishmanian test, Leishmanian test or Montenegro test. They say that Montenegro test is positive only if the CMI is intact. So patient with active VL and DCL, there the Montenegro test will be negative. They say that it is positive only when the CMI is intact, and the CMI is intact in mainly in the CL or recovered VL, whereas Montenegro test will be negative in active VL and also diffuse CL. Diffuse CL also it will be negative. So it is hypersensitivity type 4. A Montenegro test is an example of hypersensitivity type 4. Molecular tests like PCR can be done to detect the kinetoplast DNA. Kinetoplast DNA. Treatment, and okay, of course animal model will be golden hamsters. Golden hamsters are the animal model for leishmaniasis. Treatment of choice, they say that pentavalent and antimonials are the drug of choice. And this is given in most of the places except Bihar. Bihar amphotericin B is given, because Bihar the resistance to antimonial compounds have been reported, hence amphotericin B is the drug of choice in Bihar. Other anti-leishmanial drugs includes paramomycin, miltefosine. Okay, these are the other antimonial drugs. So this is all about leishmaniasis.